lecture on the inflammatory disorders of the upper respiratory tract lecture. And with the start of this lecture, I request all of you to be with me in the lecture so that anytime I can take the snapshots to be with me whole of the time the lecture. And in addition to that, I also advise you kindly write your attendance in the chat box also. Okay. And in addition to that, I also tell you uh, do also write your name as well as your ID. Name, write your name also along with the ID. Okay. Now, diseases of the nose and paranasal sinuses. Now, there first of all, let us check what is rhinitis. Rhinitis is inflammation of the mucous membrane of the nose. This inflammation can be acute inflammation, it can be chronic inflammation, and this acute inflammation, this can be caused by common cold, it can be by coryza, or it can be acute acute inflammation or acute allergic. Then chronic inflammation of the mucous membrane of the nose can be due to it can be due to the tuberculosis, it can be due to the syphilis, leprosy, rhinoceroma, sarcoidosis, and it can be simple, it can be hypertrophic or atrophic. Now, acute, what are the factors that predispose to the acute rhinitis? These include the predisposing factor, like if there is cold air, for example, cold air, or if there is dry air, there is dust, or sudden change in the temperature, all this can cause acute rhinitis. Now, pathogens, all these predisposing factors lead to the decrease of the resistance of the mucous membrane. Vasoconstriction leading to decreased blood supply leading to ischemia. This can cause the constriction of the blood vessels of the nose, and there can be, yeah, similarly destruction of the cilia. And there is the acute rhinitis causes and types. It can be there can be viral cause, there can be bacterial infection, or there can be allergic rhinitis. And what is the how you see the picture? It has a seasonal incidence. Allergic rhinitis is usually seen with maybe summer season or spring season, seasonal incidence, and it may heal spontaneously without treatment by resolution. Even if you don't treat the person will get treated automatically. He will heal. Now, if watery discharge becomes purulent, means secondary bacterial infection. So, actually, this acute allergic rhinitis, this is the discharge from the nose is watery. But if you see yellowish color from the nose or pus like, that means there is bacterial infection. Now, what are the complications of the acute rhinitis? Now, the complications include, for example, it can lead to the sinusitis. Sinusitis is inflammation of the sinuses, or there can be nasopharyngitis. The nasopharynx can be involved. Then there can be acute tonsillitis, inflammation of the tonsils. There can be acute otitis media. The middle ear gets involved. Then the laryngitis, the larynx gets involved. And of course, the acute pneumonia with the involvement of the lungs. Now, the allergic rhinitis differs from non-allergic. How? Because in allergic rhinitis, there is presence of eosinophils. There are a lot of eosinophils, and there is marked fluid discharge, and there is marked edema, and there may also be polyps may also inside the mucosa. Then this is the nasal polyp. Nasal polyp which grows in case of the allergic rhinitis as a complication. Note the edematous connective tissue. Now here you can appreciate the edema and filled with numerous eosinophils. We can magnify this. So here what we see is that these are the red color cells, with the cells with reddish granular cytoplasm. These are the eosinophils. Then there is a chronic non-specific rhinitis. Chronic non-specific rhinitis has various predisposing factors such as the nasal obstruction, the presence of chronic sinusitis, the repeated exposure to certain antigens, and repeated attacks of acute rhinitis. So, if there is again and again acute infection, it can lead to chronic rhinitis. Now, what are the types of chronic non-specific rhinitis? The types can be there can be chronic simple rhinitis, there can be chronic hypertrophic rhinitis, and there can be chronic atrophic rhinitis. Now, chronic chronic specific rhinitis, which this chronic specific rhinitis, this is the rhinitis that is chronic and due to specific causes. Now, these specific causes may be like rhinoceroma, it can be like sarcoidosis, tuberculosis, syphilis, and leprosy. You know, all of these diseases are actually chronic diseases. Now, rhinoceroma. Rhinoceroma, it is a granulomatous disease. Granuloma are formed. It's the granulomatous inflammation, and it is caused by a gram-negative bacilli, which is called as Klebsiella rhinocercomatus. And the sites it involves include it causes the rhinoceroma in the nose, then the pharyngioscleroma in the pharynx, laryngoscleroma, larynx, tonsilloscleroma in the tonsils. Now, the rhinoceroma features of pathological features of rhinoceroma include the early cases. There can be diffuse form or there can be nodular form. In the diffuse form, there is diffuse thickening in the mucous membrane of the nose, and in the nodular form, there the mucosa is irregular with the presence of nodules and polyps. Then the late cases. In the late cases, if we don't treat the rhinoceroma, ulcer formation develops. There will be ulcer formation that spreads to the lip and the palate and the cheek. Then if we treat and it gets healed, There can be stage of healing, there can be excess fibrous tissue, there can be, or it may healing may cause deformity of the nasal cavity when there is scarring and there is not proper healing. Then there is microscopic picture of the rhinoceroma. If we see, there is squamous metaplasia of the covering epithelium. What happens is that there is the lining changes to the squamous lining, the mucosal lining uh, changes to the squamous lining. That is what we call as squamous metaplasia, and the blood vessels dilate, and there is infiltration by the chronic inflammatory cells, and there are the numerous plasma cells and the histiocytes, and you see the Russell bodies. These are plasma cells with a hyaline change, pinkish change. And then there are the Mucklick cells. These are also large vacuolated cells. These are macrophages. In the granular matter stage of rhinoceroma, the mucopolysaccharide was found within the mucosal cells. Okay, leave this. Remember this thing. Russell cell, Mucklick cell. This is more important. Now, this is the microscopic picture of the rhinoceroma. Now, granular matter stage with chronic inflammation with numerous plasma cells. What you see here, is that there are the numerous plasma cells, there are the numerous lymphocytes, and characteristic large clear to vacuolated Mucklick cells or macrophages. Now, here you see large Mucklick cells. These are large macrophages, and macrophages are these are vacuolated, so we call them as Mucklick cell. These may contain a few this bacteria and mucopolysaccharides. Now this is the rhinoceroma. What is the complication? Complication is when it does not heal properly. As I told you, it may lead to the deformity of the nose. Here you see complete obstruction of the nose and the pharynx, and there may be deformity of the nose. Then there is the chronic sinusite. Chronic sinusitis is when it occurs with the repeat attacks of acute rhinitis and acute sinusitis. The disease is chronic. We call this as chronic sinusitis. Extension of infection from related septic tooth, or the infection goes to from related septic tooth. Then chronic sinusitis complications is this chronic sinusitis, this infection from the sinus. It can go to the orbit, the intraorbital cavity. It can go to the cranial cavity. It can lead to the closure of the ostium of the sinus, and the accumulation of the secretions in the sinus. So sinus opening may get blocked and it may damage the sinus. If sinus exudate is pyogenic, it may lead to formation of pus in the sinus. We call it as sinus empyema, or if it is serous, it may lead to sinus mucosal. Then there is diseases of the tonsils. Tonsils there can be acute tonsillitis, there can be chronic tonsillitis. Acute tonsillitis can be caused by various bacteria like diphtheria, also and other streptococcus, etc. And chronic can be with specific diseases such as tuberculosis, syphilis, or scleroma. Then non-specific, uh, it acts as a septic focus harboring the organism. Acute tonsillitis. Acute tonsillitis, as I told you, it is caused by streptococcus hemolyticus. Is seen in children. Usually, both the tonsils are involved. It can be follicular, it can be catarrhal, or it can be parenchymatous. This again you will read in the ENT block when you in the senior inshallah. Acute catarrhal tonsillitis, it can be one tonsil or both tonsil involved. It is limited to the mucous membrane of the tonsil. The tonsils are red and they are status and they are very large. Acute follicular tonsillitis, they are there is suppuration, pus formation on the lymphoid tissue surrounding the crypts of the tonsils and purulent acids rich in the cells. Accumulation of pus in the crypts leads to yellow dots or follicles. So this is follicular tonsillitis in which the crypts they are filled with pus. These follicles These follicles may coalesce to form yellow membrane or membranous tonsillitis. Membranous tonsillitis. These follicles they then fuse together and it leads to membranous tonsillitis. And if we see a case of acute follicular tonsillitis, the tonsils are red, they are congested, enlarged, and dotted. Now, this is the acute follicular tonsillitis. The crypts of the tonsils they are filled with pus and exudates, and as a result, they form this like follicles. So, this we call as acute follicular tonsillitis. Then there is acute parenchymatous tonsillitis. In this, there is suppurative inflammation of the whole substance of the tonsil. Parenchyma means the substance of the tonsil here. So the substance or the inner part of the tonsil is involved in parenchymatous tonsillitis and suppurative inflammation of whole substance of the tonsils, and usually it is involves both tonsils. Now, acute tonsillitis, it early complication include, in case of acute tonsillitis, the infection may spread from the tonsil to the surrounding or paratonsillar area and form an abscess in the side of the tonsil, and we call this abscess as quinsy. It's a medical term used for paratonsillar abscess. Then it can cause rhinitis, sinusitis, it can cause pharyngitis, laryngitis, bronchitis, otitis media, and pneumonia. Then the lymphatic spread, it can spread the tonsil infection, can spread through the lymphatics to the draining lymph nodes and the submaxillary and the upper cervical group of the lymph nodes may get uh, swollen. Then, if this infection goes through the blood, it may lead to septicemia or sepsis formation. Then, the late complications are related to the hypersensitivity, the free of organisms. The person can get free of organism. There can be hypersensitivity. It occurs after 2 to 3 weeks. And if it is caused by streptococcus, there may be rheumatic fever and acute diffuse post-streptococcal proliferative glomerulonephritis. This is all if this acute tonsillitis is caused by streptococcus infection. Then there is diphtheria. If this is by diphtheria, this is caused by coronary bacterium diphtheria and associated with severe toxemia, and it is common in children of 1 to 10 years of age. Here we see pseudomembranous. Actually, diphtheria, a false membrane or a pseudomembrane is what we see. Toxins stimulate a necrotic inflammation of mucous membrane. And what this membrane is of, this is of adherent gray pseudo membrane on the mucosal surface. And this membrane, if we take it off, it is composed of the dead cells, the necrotic cells, and the microorganisms, the corynebacterium, diphtheria, and the fibrin as well. Then there is the Wagner's granulomatosis. Wagner's granulomatosis it is actually a granulomatous disease. It involves the respiratory tract, both the upper and the lower. There is necrotizing vasculitis of small blood vessels. So the small blood vessels are involved, and what happens with these small blood vessels? There is necrosis of these. The etiology is unknown, and males are affected more than the females. The age is more than 40 years of age, and it usually involves the lungs are involved. As I told you, the disease involves the upper and lower respiratory both. So lungs are involved, the nose are involved. So what happens in the upper respiratory tract is that there is ulcerative lesions in the nose, the palate, and the pharynx. Then the necrotizing granulomas, granulomatous disease, necrotizing granulomas, rimmed by lymphocytes, plasma cells, macrophages, and giant cells, and vasculitis of small and sometimes large arterioles and veins. Then there is diseases of the pharynx. Pharynx can be acute pharyngitis, inflammation of the pharynx. Usually, it affects the nasopharynx also involved. Uh, then oropharynx and laryngopharynx may be involved uh, uh, in it, and it is caused by commonly caused by streptococcus pneumolyticus. And we see the mucosa, it is swollen and it is edematous, and there is a discharge from the nose or the oral cavity. Now, this is what are the complications of the acute pharyngitis? Is that it can lead to the rhinitis. Rhinitis, it can cause the inflammation. If the infection spreads, it can cause the rhinitis, it can cause sinusitis, it can go through the eustachian tube to the middle ear, cause otitis media, it can cause the bronchitis, it can cause bronchopneumonia. Then similarly, it can also cause retropharyngeal abscess. That means behind the pharynx, it can cause abscess. Retro means behind. Then it can also cause glomerulonephritis. We call this a post-streptococcal glomerulonephritis if the infection spreads through the blood to the kidney. Then it can also cause rheumatic fever because it is due to streptococcus infection. Then these are the references you can read further from the Robbins. I recommend you to be stay in touch with me till I record the attendance.
يا اخوان لا يطلع بياخذ التحضير.
Hold on, hold on. I am recording attendance. Give me a quick daqiqa till I record the attendance.